So we now move on to refractory idiopathic intracranial hypertension. What would be your choice? Would it be optic nerve sheath fenestration or would you do an LP shunt? And to speak for ONSF, Dr. Ambika.
Okay, thank you so much. And I'm going to move on to optic nerve sheath fenestration per se, because I'm not going to restrict my talk only for refractory, because we have a lot of IIH patients presenting in chronic stage also who would require this technique. So I'm going to keep it as IIH and the role of ONSF in that aspect. So ever since Divika brought this, it was Hyre who showed that sheath fenestration will be useful for papilledema patients. And this is this area which is we are more concentrating on immediate retrobulbar area, where there is a, I mean, it's rich in blood supply. You have to be very careful if we are planning a technique. And this is this area where we are going to decompress the optic nerve of the CSF, which is compressing the optic nerve. So by and large, the technique is we make a slit in the optic nerve sheath, or we can make a window and we decompress the optic nerve and let out the CSF fluid. That's the technique. So when do you apply this? So the mechanism of action is it's a subarachnoid scarring at the fenestration site, and it could function as an ICP gradient towards the posterior part of the optic nerve, or it's an egress theory of the fenestration or the Bernoulli's theory of fluid dynamics. So here is the indication. So I'm going to talk on the indications from an ophthalmologist perspective. I think we all are ophthalmologists. So we would do techniques which are easily in our axis, and the patients presenting to us are with predominant visual symptoms. So you have to find a patient group which has a chronic IIH, atypical IIH like cerebral venous sinus thrombosis, AV fistulas, intracranial mass, aseptic meningitis, or a sheath hematoma. These are the common indications where we do apply a sheath fenestration. The next group is the refractile IIH, where there is a progressive visual decline, visual field loss, and when they are medically not responding to the treatment, and OCT is showing a gross fluid accumulation, more than 300 thickness of an RNFL, generally they don't do that well with medical treatment. And if the opening pressure is beyond 35 millimeters of water, probably that's the case which you have to rest with a surgical technique. So this is a patient who is a 57-year-old male who came with a chronic history of drop in vision, gradually progressive over 3 years, and he's already had a shunt by his local neurologist. So when we saw the patient had a hand movements vision, in right eye was grossly down and that of the left eye had 624 vision, and you could see there's a gross asymmetry of the disc edema. Here you are having a pale disc which is trying to settle down the edema, and then another disc which is having significant edema. So this is the visual field what you had seen, the patient had elsewhere. So there's a gross field loss, and right eye is hardly there's any central island preserved, and MRI brain did not show any atypical features. So we went ahead and performed the better eye, which had a good vision in the left eye. We proceeded with the sheath fenestration because that had maximum fluid which can come out on our sheath fenestration, but definitely it has its own demerits too. And this is the day one result of the sheath fenestration, and this is what he looked like on 2 months follow-up. So there's a definite reduction of the fluid in the fellow eye, and this is his visual acuity and follow-up, and you can see the visual field by 7 months. So that was the better eye. So this is the improvement what you get with the ONSF. So you see a visible change in the visual parameters. So this is the OCT on initial, and then there's a gross RNFL and a GCC loss. So now the question is, my friend, Dr. Guha is not going to accept that we are going to settle down with a sheath fenestration just like his Bengali friend. Now let me say that ONSF is in our hands. The patient is coming to you as an ophthalmologist with a progressive visual decline. When a patient is coming with that, no atypical features, no neurological features, and your neurologist is saying, madam, vision is coming down, please take over. So there you have a real surgical technique which can help you. Go ahead, fenestrate him. Don't wait for the neurologist to open the window for the vision. So he's going to open only the shunt. He's not going to come back. And even after shunt, this patient what I showed is post-LP shunt. So even after shunt, there are indications for sheath fenestration. So let me rest that sheath fenestration has its own benefits, but yes, it has its own cons. It's an early threat to the vision. You need a lot of clinical expertise to do the procedure, and sometimes you may need a complementing CSF diversion procedures. And there are a lot of literature articles which are supporting that yes, it improves the vision as well as the visual field. And this is a 20-year multicentric retrospective data which showed that yes, sheath fenestration had almost 50% of them reached a best corrected visual acuity, and more than 80% of them did recover or stabilize. And sheath fenestration in the setup of a secondary atypical IIH, that's where we have the glitch. The patient is having a transverse sinus stenosis. So here an early ONSF will improve and stabilize the vision, because once you let the patient go to the neurology wing, he's going to go into the interventional neurology guy and he's going to stent him. If they stent, he's going to put him on anticoagulants and that's it. So once they have done it, you are not going to do the sheath fenestration that easily. So fenestrate the patient prior to a venous sinus stenting. That makes the key in secondary atypical IIH. And this is another study which showed that yes, even in cerebral venous sinus stenting, there is a role of a ONSF. And there is interestingly a MORE group have come up that not only once you fenestrate, you can do secondary and tertiary fenestrations, which mean even after doing once a fenestration, there is a scope for the subsequent fenestrations. So these are the various routes how you can go, and I had shown the video. And the only advantage of a medial transconjunctival approach is it's a quick access. You don't need to have an external incision, and there is an increased operating field. But I can make one thing is there's a lot of fat prolapse, what I had experienced. So identifying the optic nerve may be really difficult in a medial conjunctival or any other approach what you would see like this superomedial or a lateral orbitotomy approaches, and it has its own complications to certain extent. If you're a good ophthalmologist and she's a very good squint surgeon, I know why she's talking for shunt. So you have very minimal complications with optic nerve sheath, but yes, there are potential complications right from retinal artery occlusion to traumatic neuropathy to significant orbital infections and squint and diplopia. As I mentioned, there are a lot of contraindications for ONSF when a patient is on anticoagulant, when there are CNS infections, when there is a mild to moderate vision loss, you can definitely manage them with the medical therapy. And if it is not indicated for headache management, and when there is no gross disc edema, maybe you have to sit and think back whether before touching that eye. And it is a safe and effective procedure. Medial transconjunctival is having a quite good access, but bilateral papilledema, it is better to